Very good morning, everyone. Welcome to ISA Masterclass. This is the 15th Masterclass in a series, and welcome all of you, not only from India, also from neighboring countries. Last week we had one wonderful talk by Dr. Salimar, and he spoke on autoimmune hepatitis, and we got a lot of feedbacks, and a lot of people liked his talk. Thank you, Dr. Salimar. And he has also responded to all the questions, which we will be posting, all the responses to all the questions today. Now, yet one other topic which is very important for we gastroenterologists, and that is neuroendocrine tumor. While doing endoscopy, you find many a times a small polyp either in the first part of duodenum or in the colon, and they come out to be NET. The question is, how do you manage these patients? How do you do further investigations and further diagnosis and further treatment? And this is an important topic for all of us. And for this, we have Dr. Amrinder Singh Puri. I think everybody knows Dr. Puri, very articulate. He had been the head of Department of Gastroenterology at GB Pant Hospital in New Delhi. Now he has moved to Medanta Medicity in Gurgaon. Dr. Puri, all of us know that he's a great teacher and a wonderful speaker. The artistic way he makes his slides or he speaks is always a treat to listen to Dr. Puri. So we welcome Dr. Puri for this masterclass, and we are so happy that you accepted our invitation. And to moderate this session, we have Dr. V.G. Mohan Prasad, a very well-known gastroenterologist, not only in India but other parts of the world. He's a very senior gastroenterologist from southern part of India, that is Coimbatore, and he is very well known. So he has agreed to moderate this session. Now I hand over to Dr. Saraswat to welcome you and take the proceedings further. Dr. Saraswat, please.
Thank you, Dr. Govind. Good morning, ladies and gentlemen. Welcome all the attendees and all the participants to this series of ISG Masterclass that's been ongoing since the 15th, 16th of April. We are now into our completing our second month of sessions, and I am happy to note that the interest of the audience is as sustained as ever. We have a committed and active group of participants, and it's always a pleasure to initiate and to run these sessions on the ISG Masterclass. As Dr. Govind has told you, neuroendocrine tumors will form the subject of the Masterclass today, and predominantly GI nets, mainly GI nets will be covered in the presentation today. And for that, I think he's already introduced Dr. Amrinder Singh Puri. Amrinder is one of the alumni we are really proud of from SGPGI. In fact, if I'm not wrong, you are number 3 on the leaderboard of SGPGI alumni that we have in our seminar room. And he has had a very distinguished career in Delhi since he left the portals of SGPGI and rising up in the hierarchy at GB Pant, and then taking over the mantle of leadership there once Professor Sareen moved to the new setup in ILBS. And he has he's a man of varied interests not just in the GI tract, from endoscopy to luminal to malabsorption IBD, but also doing a lot of procedures, and varied interests beyond gastroenterology. I don't think I have I'm qualified enough to talk about them beyond noticing that his Eid calligraphy greeting in Urdu was masterly this year, which I remember. So with these few words, and also a great hi and welcome to VG. It's always nice to have VG, another one of my good friends and a very articulate person himself, and who's leading a very impressive series of webinars in the southern part of the country during this lockdown period. So with these few words, I now invite Professor Puri to present the topic of GI nets to all of you. Thank you. Puri, please.
Thank you, Dr. Saraswat. It is indeed a humbling experience because, as you would remember, I started my residency when you were on the faculty along with Dr. Nayak and Dr. Chaudhary. So it is really a humbling experience. And thank you, Dr. Govind, for giving me an opportunity. Dr. Govind has given me the topic, which was rather restricted, of incidental neuroendocrine tumors, but I thought I would expand on it. And so the outline of my talk is going to be under these 6 headings. As you can see, I'm going to start with the pathobiology and move on to diagnosis. So what is the diagnostic algorithm if it's there? And then I'm going to talk about the general clinical presentation of neuroendocrine tumors. And the specifics that I'm going to take is gastric, that is stomach, duodenum, and rectum. And the reason for choosing these is that these are the ones that we are most likely to get as incidental tumors, since the theme is incidental neuroendocrine tumors. And for obvious reasons, one being we have just about 45 minutes or so. So I've left out pancreatic neuroendocrine tumors and small bowel, specifically the ileal neuroendocrine tumors, which are rarely detected as incidentalomas. A brief word on the neuroendocrine system. It is, I wonder if the endocrinologists know this, that it is the largest endocrine organ of the body. There are at least 14 different cell types. We're going to be discussing about ECC, which is the enterochromaffin cell, enterochromaffin-like cell, D cells, L cells. So there are 14 different cell types like this, and they produce between them about 30 different peptides. But the common denominator is that all neuroendocrine tumors are derived from these neuroendocrine cells. And these neuroendocrine cells, they are categorized into 3 very broad categories. So as you can see on your slide, right on the top is the ECC, which is the enterochromaffin cell. This is the most common neuroendocrine cell in the GI tract and specifically in the small bowel. Then we have the 2 other categories that you can see. One is open and one is closed. What does open and closed mean? In my subsequent slides, I will give you more pictures of these so you can understand them better. An open cell means that a cell which can discharge its secretions into the crypt. So examples of this are the L cells or in rectal neuroendocrine tumors, and a closed cell, the prototype of which is the ECL, means that it cannot discharge its secretions or contents into the lumen, the crypt lumen, but it can go elsewhere in a paracrine fashion. So these are the broad headings that we have for neuroendocrine cell types. Oops. I'm sorry, the slide seems to have got... Okay. Now, I thought I'll take a little bit of microanatomy because not many people, or at least some people maybe not be very familiar as to which is the area in the intestine that we're talking about. So this is where we are. You can see these are the long finger-like villi that you can see very clearly, and I would suspect this is from either from the jejunum or some other part of the proximal ileum. Very long finger-like villi. And this is the base of the crypt. And the base of the crypt is actually where the factory is, where the cells are manufactured. So this is your stem cells, and the stem cells alternate with the Paneth cells. But if we grow a little higher, then you can see there's one red cell labeled in red here, there's another one. These are the enteroendocrine cell or the ECC, enterochromaffin cells. So we are talking about these cells and their secretions. And in some people, these endocrine cells, neuroendocrine cells, they become tumorous. And that's the topic for today. Just these 2 slides, these are morphological considerations regarding the size of the primary tumor. So in general, the neuroendocrine tumors are usually small, and the size that is given is they are less than 3.5 centimeters. But what is important is that there is a discordance between the size of the primary versus the lymph node or the liver mets. So we can actually have a very small primary in the ileum and large mets in the liver, a small primary in the rectum, large lymph nodes or mets in the liver. Now you compare this with the garden variety of the apple core lesion in the left side of the colon, which is characteristic of adenocarcinoma, and there'll just be a small met in the liver. And that small met makes it inoperable, at least curative for that matter. So here it's the other way around. It's the primary tumor which is small and the deposits which are much larger. The rectal tumors always less than 3 centimeters. So we can say that most of these neuroendocrine tumors are going to be less than 3 or 3.5 centimeters. They really don't grow any bigger than that. And then there's a correlation of the size of the tumor with the malignancy. And this is generally a rule of the thumb. So the rule of the thumb is if the tumor size is less than 10 millimeters. Now here I'd like to add that as yet there is no endoscope which has a fitted vernier caliper that you can exactly measure the size. This is a rough, and mostly we go by the size of an open biopsy forceps. So these are somewhat rough indications, but coming back to that, so if the tumor size is less than 10 millimeters, the tumor is usually benign with one major exception. And maybe at the end of my talk, I think Govind can ask this and I will give you the answer at that time. And that is important, and I'm keeping it as a secret. So one major exception which defies this law that the tumor is less than 10 millimeter, then it's going to be benign. If the tumor size is more than 20 millimeters, then it is usually taken as malignant. And these tumors, one would be hesitant to take it up for anything other than surgery. But between 10 and 20 millimeters is the gray zone. So you can possibly consider endoscopic surgery if everything else is feasible, which means there are no lymph node metastasis, there are no, it hasn't gone down into the musculus propria, then you can consider. So we go by the other features also, but this is a gray zone for tumors between 10 to 20 millimeters. And mind you, this size refers to the lesions seen at surgery or during endoscopy. We're not talking about formalin fixed specimens, because after you put it in formalin, they shrink. So this is not the pathological or the pathologist's perspective. This is the clinician or the surgeon's perspective. Just to give you an example of the fact that you have a small primary tumor. So on your screen, you can see there is a tumor over here. This is a submucosal tumor. This is just about 10 centimeters from the anal verge. You can see this is a submucosal nodule, you can see. Very innocuous looking, you know, the kind that when one thinks they're so innocent that butter won't melt in their mouth. And this is what it does. So here you can see that there's a large deposit in the liver, and there's another one over here. So this is what I was trying to tell you earlier when I said that the tumor being small and the mets being large. So there's a disproportionate between the size of the primary tumor and the deposits in the liver. So now I move on to the second part of my talk, and I have 2 or 3 slides on this as a general introduction. What should be the diagnostic approach to a neuroendocrine tumor? I have 2 slides on this because one of the residents asked me, "Sir, you are so confident when you see a patient who has multiple nodules, submucosal nodules in the stomach, and you had seen him in the OPD earlier. You asked for a gastrin and chromogram level, both are elevated. Now you're absolutely certain. So do you really need a biopsy?" So that set me thinking. So this is one diagnostic approach to neuroendocrine tumors. It doesn't cover only stomach. This is in general. So if you have a submucosal lesion, a polypoidal lesion, or a nodular lesion in the stomach, in the duodenum, or in the rectum for that matter, and you pick it up at endoscopy, then in some larger centers which are very active in EUS, possibly the same sitting the patient is taken up for the EUS, and we determine which layer it's coming from or whether the musculus propria in particular is getting infiltrated or not. So this is probably done in the same sitting. So that's why I put them together. But if you don't do that, that's all right. It can come later as well. So the next step, because if this was patient came with non-specific symptoms and all you had was this lesion, then the next thing automatically, as far as the stomach is concerned, one should go for serum gastrin levels and serum chromogranin levels. For larger lesions where we suspect this may be more sinister, we go for a cross-sectional imaging. I've used the term, I've shortened it to CSI. So CSI stands for cross-sectional imaging, which can be CT or MRI. Mostly it is the CT. And finally, when you want the proof, as we're actually dealing with a neuroendocrine tumor, and more importantly, is it a localized disease or is it a disseminated disease? Then we will get a DOTA or one of the nuclear scans, which I will be discussing subsequently. This is a diagnostic approach, the alternative pathway, let's put it this way. So what can be done is you can go for the endoscopy and the EUS, and there at endoscopy, you take a biopsy, and subsequently you go the same pathway. As far as stomach is concerned, you would go for gastrin, chromogranin, cross-sectional imaging, and DOTA. If it was a non-stomach, then there is no need. For duodenum, I wouldn't get gastrin levels done, obviously. For rectum, we can just go to chromogranin levels and go straight away to cross-sectional imaging and the DOTA scan. So we have two pathways and you can choose whichever one suits you. So this is the example that I gave. When you have a patient incidental and you have multiple polyps in the stomach all lined up together, then in all likelihood, there cannot even be a differential diagnosis to this. This has to be a neuroendocrine tumor. Going on to imaging. So cross-sectional imaging, I have just one or two slides only. And here you can see this is the stomach. There's a fluid level, that contrast is gone. And it's lighting up like a bulb. A small bulb, but it's lighting up. So that is one of the characteristic features of neuroendocrine tumors, that they light up like a bulb. They're really very avid contrast uptake. So this illustrates this point very nicely. And sometimes you can even do a virtual gastroscopy. So here you can see the typical appearance. This is one lesion, then there are 2 or 3 smaller lesions, but this is the lesion that I want to focus on. And you can see that this is, there is a central depression, what the Western literature refers to as donut-like appearance. In India, I think the closest we can think of is the sambar vada. So this looks like a sambar vada with a central depression. And this can also be done and seen if you do a virtual gastroscopy. And then just going past the serological markers for stomach, as I mentioned, we would get serum gastrin levels. The others, we can also get serum chromogranin levels. They're usually elevated. The point that I wanted to emphasize was that if the patient is on PPI, and this is not the exception, this is the rule. Most patients who've been having dyspepsia are already on PPI. And if you pick up these lesions, then don't be in a hurry to get their serum gastrin and serum chromogranin levels, because they will be falsely elevated. So ideally, these patients should be discontinue their PPI for at least 2 weeks, or at least for 1 week, before testing for both these markers if they are being used for decision making. And the last of the diagnosis is yours for radionuclide imaging, which is the DOTA scan. And here I've taken a concept. I think most of the residents would recognize this picture is actually that of coronavirus, which is everybody has become very familiar with this, and you can see these things sticking out. Now, if you have a neuroendocrine tumor, then this is exactly how the somatostatin receptors are. So neuroendocrine tumors are one unusual group of cells which express somatostatin receptors, and this property has been used excellently to make a diagnostic test, which I'm been discussing out. So 90% of neuroendocrine tumors have surface somatostatin receptors. SSTR is the short form for that. And here I want to mention that the exception to this is insulinoma. So in insulinoma is the only one, for some reason, we don't know the answer as to why the insulinoma, which is also derived from the neuroendocrine, does not express these somatostatin receptors. So a DOTA scan is not a great idea if the patient is suspected to have an insulinoma. But for all the others neuroendocrine tumors, it is an excellent modality. So what is the principle of the DOTA scan? This slide is inspired by a Hindi movie in which there was a very obese Havaldar. I think it was Asit Sen, and he manages to get hold of two crooks. And he has only one pair of handcuffs. So he puts one, he can put one loop on the one guy and the other loop like this. So when the seniors comes and he was alone, so when the inspector comes and say, well, why did you do this? So he says, this way, but they both can't run in two different directions and it'll be easy for me to chase them. But coming back to that, so this somatostatin, you can see over here is the chain. And incredible, isn't it? It has markers, it can link on to the somatostatin receptors on the neuroendocrine tumor, and it can link up to gallium. And if you label that with a radionuclide 68, then you get the DOTA scan. So everywhere where the somatostatin receptors would be, the somatostatin would bind and you have gallium 68 and that will be picked up. And the end result of this is what you see over here. So you can see there is a lot of golden yellow activity over here and there's another activity in the stomach. And the central part is not golden, it's become necrotic. So where the cells are dead, there'll be no activity, and the cells, the active cells, the actively multiplying cells which are taking up the FTG are outlined here and here. So this is the principle of the DOTA scan that we can use. So you can use DOTA Talk, DOTA Knock, whichever one is available in your city, in your institute. And lastly, I'm just touching on histopathology. So histopathology, you can see that the tumor is submucosal. It tends to lift. Here you can see my cursor is outlining the MM, which is the musculus mucosa. This is the surface epithelium here. And you can see the crypts over here. So this is the tumor cells, absolutely monotonous cells, and they're kind of lifting up. So you don't get a nice stalk like we get in other polyps. For example, in the Peutz-Jeghers polyp, you have a lovely thin stalk. So here you'll never have a thin stalk. It'll be a very broad kind of a stalk because this is all tumor tissue. In a Peutz-Jeghers polyp, we have a fibrovascular bundle. So here we're not having any fibrovascular bundle. This is all tumor tissue. So therefore, we always have broad stalks. And a higher power, just for the orientation of this slide, on the bottom right corner, this is the luminal aspects, and you can see the crypts. And this, where my cursor is running down, is the musculus mucosa. And this means the tumor cells have split the musculus mucosa and gone into the submucosa. And here you can see very nicely the absolutely cloned, monotonous cells of a neuroendocrine tumor. As far as histological grading is concerned, they are different. They're categorized into three categories. Like we have the ordinal data. So we have well-differentiated neuroendocrine tumors, and most of these are less than 1 centimeter. Then we have well-differentiated neuroendocrine carcinoma, which are usually more than 20 millimeters. And of course, the highly malignant is the poorly differentiated, which starts resembling the oat cell tumors. So these are the high-grade tumors. But as far as the WHO classification is concerned, the ENETs grading is G1, G2, and G3. And you can see over here is the mitotic index. So for a G1, it will be less than 2. The Ki67 will be less than 2%. And the WHO classification would be NET G1. For G2, it is between the mitotic index is between 2 and 20. The Ki would be between 3 and 20%, and this would be classified as G2. And similarly for G3, it's always more than 20, and Ki67 is more than 20%, and this would be classified as a neuroendocrine carcinoma or G3. What I really never understood is that there is excellent concordance between the mitotic index and the Ki67. So why can't we just use one instead of both? But most pathologists would still mention this mitotic index and the Ki67. And if you can see, both of them are absolutely concordance with each other. So now going on to the clinical presentation of GI nets. If we classify their symptoms, then it can be a true silent incidental pickup. This happens possibly the most commonly in clinical practice. And so these are referred to as incidental. You put in a patient has a dyspepsia, you do a gastroscopy, and there you find these lesions. The second category is where the primary is silent and the patient presents with the METs are detected and the METs become symptomatic. So here the primary is silent, but the patient may be symptomatic because of the METs. And the third category of symptoms correspond to the hormone producing tumor. So it can be a carcinoid syndrome or the fainting spells associated with insulinoma. So this is the hormone producing tumors, which I won't be discussing today. Maybe we can take it up some other time, but I would be concentrating essentially on the true silent or incidental neuroendocrine tumors. So Govind asked me that it would be better that you take up a case and take it up from there. So this is one of our recent cases. She's a 40-year-old female, and she had an incidental injury about 2 weeks ago. She said she had an old chair at home and she sat down to do some work. The chair broke, she fell down, and she hurt herself in the lower part of the rib cage. And since the pain persisted for almost up to 2 days, they went and got an ultrasound done, and that showed some alarming features. But when I asked her the history, she said, my appetite is excellent, I have no weight loss, and she was ECOG grade 0. And when I examined her, it was completely unremarkable, except the left lobe was palpable and firm, and that I found out of place. But otherwise, this patient was absolutely asymptomatic, and you can see that she has, I won't say chubby cheeks, but certainly they're not, the zygoma is not sticking out. She has some, if you look carefully, there is some fat in the neck as well, and she's very well preserved, and she was doing all her household work. So when we went in, this is what we saw, and it was a real surprise. And this is what is referred to as a double pylorus appearance. This is not the pylorus. The pylorus is in this direction. If you can see carefully, this is the incisura arching up. The incisura is infiltrated, and so is the antrum completely. It's been lifted up, and this is a deep excavating ulcer. Medicine is strange, isn't it? You have a patient who has a 5-millimeter duodenal ulcer, and he would have so much pain that he gets up at 3 o'clock and he's rushing to the doctor. And here this lady, she had almost a well in the body or the antrum of the stomach, and she was completely asymptomatic. So for the orientation, you can see that this is your anterior wall where my cursor is, and this is the posterior wall. The incisura is merging. So if this patient was to be taken up for the CT scan, I would expect this ulcer to be just below the rectus muscles. So this is what we saw. You can see that's the rectus muscle, and that's a deep excavating ulcer, which was giving a pseudo pylorus experience. And here you can see the thickness. The antrum is completely replaced by this tumor. And yet this patient was completely asymptomatic. We can never explain this in medicine. So now coming on to the incidental detection, what we see in clinical practice, incidental tumors would come largely, I think by far the bulk of them would come from the stomach, duodenum, because gastroscopy covers both the stomach and the duodenum. The small intestine and pancreas are not covered in incidental tumors because there must be a good reason for you to do an enteroscopy. The patient must be symptomatic, so he cannot be incidental. Appendicular and colorectal, yes. Colorectal for us and appendicular for the surgeons. So I would be talking only about these three sites, namely the stomach, the duodenum, and the rectum. When we talk of the clinical presentation, approximately 50% are discovered incidentally. And incidentally means it can be discovered at endoscopy, at surgery, or at autopsy because they were silent all through. And the reasons that they remain silent is, one, they are indolent. They are not, they don't have an urge to go and form metastatic lesions in the liver and elsewhere. They would rather lie like an indolent dog in one corner for many months or years. And second, because they are of their small size, they don't cause obstruction. So they are lying there. So that is the two reasons why most of these patients are asymptomatic. But on the whole, if you take the whole gamut of clinical presentations, so one, as I said, it can be totally non-specific. And then the other specific ones can be abdominal pain, nausea, diarrhea, which is a feature of ZE syndrome. Intestinal obstruction occurs mainly in small bowel tumors because of the desmoplastic reaction in the mesentery, which causes kinking and thereby leading to intestinal obstruction. The classical carcinoid syndrome accompanied by flushing, or we can have specific symptoms of insulinoma, which is repeated episodes of fainting, or a very severe diarrhea, almost like a choleric-like presentation in lipoma. So these are some of the clinical symptoms that are associated with the neuroendocrine tumor. And now from here, I go on to the specifics. So I'm going to start with the stomach. So gastric nets, if you see, on the whole, they comprise of less than 5% or just about 2% of all gastric tumors. In other words, gastric neuroendocrine tumors are uncommon and you don't see them. They're not seen so frequently that everybody would be seeing them every day. So they are uncommon tumors. But what we do know is that over the last 2-3 decades or more, we are seeing more and more of these lesions, mainly for two reasons. One, there is increased awareness amongst all the physicians and gastroenterologists. And second, our endoscopes have become so good, the resolution is so good that even 3, 4, 5 millimeter lesions are easily picked up. And this is the point that I was trying to make, that in the since the 1970s, there has been a sudden spurt or a steady increase in the proportion of gastric neuroendocrine tumors. This is from Sherbel's group, who's one of the leaders in neuroendocrine tumors. And this is the graph. Then you can see that in 1970, it was just about 2%. And subsequently, this went up to 5.8%, and around almost 9% is the proportion. Gastric neuroendocrine tumors account for, let us say, if we round it off, between 9 to 10% of all GI nets. Now, the reason for this is obvious. You can see that endoscopy or gastroscopy entered the market, so to say, somewhere here in the mid-70s. And after that, it's been an upward trend for the diagnosis of these tumors. I tried to get my hands on some Indian data on neuroendocrine tumors. This is the data from TMH Data Memorial, which was published 3 years ago, small series, 40 cases. But here I want to emphasize that when you look at the surgical series, they would never have the incidentalomas. So most of these patients would be symptomatic, and that's why they would be very different from the data collected by medical gastroenterologists, or if you look at a broader perspective, because here the surgeons would focus only on the symptomatic. So what they said was that the commonest site in this series was stomach, duodenum, and rectum, and they did surgical resection in almost 70%. And most of these patients the mean age was 60 years. But of course, as I mentioned, this is a surgical perspective. Now, talking of, let's go into the details. of gastric nets. You can see this is, I've got the gland over here, and this is the mucous neck cells. The cells in blue are the parietal cells. The parietal cells, you know, secrete acid. And over here we have the chief cells, the zymogen, and they secrete pepsinogen. And in the background, you can see two different cells. One is a G cell, and this is the ECL cell. Because the small intestine enterochromaffin cells were discovered earlier, so they were called the enterochromaffin cells, ECC. And this probably came later, so they said these are enterochromaffin-like cells, ECL cell. But what is important, and what I want to emphasize is, this is a closed cell. So the secretions of this cell do not go into the script path over here. The acid goes in over here, the pepsin goes in here, the mucus goes in here, but this, there is no outlet for the ECL. So at best, it has a paracrine effect on the parietal cell only. And here I've also shown that it is in close relation with the G cell. So if we go on just for a brief moment for the pathophysiology of acid secretion, you can see that that's the G cell, the cartoon diagram of the G cell, and this secretes gastrin. And there are two cells which have gastrin receptors. One is the ECL cell, and the other is the parietal cell. So that's the receptor for the gastrin, and that's the ECL. After it gets activated by the gastrin, then this secretes histamine. And histamine is a secretagogue for the parietal cell. So what we were using earlier was the H2RA, histamine H2 receptor antagonist, the cimetidine, ranitidine, etc. And this is where they used to act. But coming back to, so once the gastrin acts on the E cell, when there is hypochlorhydria as a feature of, say, chronic atrophic gastritis, which is usually due to H. pylori, then since it has a trophic effect, these will go on multiplying. And that's how we get the tumor. So pathogenesis would be chronic atrophic gastritis, increased gastrin levels because there is a negative feedback. There's no acid in the stomach, so increased gastrin that we can see. This leads to proliferation of the enterochromaffin-like cell or the ECL cells. And from proliferation, hyperplasia, we go to dysplasia. From dysplasia, we go to tumor. So it can be referred to as an ECLoma. So that's how the neuroendocrine tumors are formed. Now coming back to practical stuff, when you have a patient who's suspected to have a GNET, which is a gastric neuroendocrine tumor, then how do you go about it? So the recommendation is that you would take 4 biopsies from the fundus. You would need to take 2 or 3 biopsies from the antrum as well, because you want to stain for H. pylori and you want to show that there's atrophic gastritis. So you need to show in the antrum. And then from the multiple lesions, as I said, you can take biopsies from the polypoidal lesion. And once you've taken the biopsy, do not forget to inform your pathologist that we want an IHC for chromogranin, for synaptophysin, and for Ki67 and mitotic index. So these things must be done by the pathologist. The EUS is the best technique that we have currently for determining what is the size and the depth of the penetration. You can get the most accurate values for both the size and the depth of penetration. When we're talking about the depth of penetration, the only thing that we're concerned is that it shouldn't, the musculus propria should not be involved. I have a slide on that. I will discuss that subsequently. And of course, you have to have a CT scan in these patients, especially the ones with a type 3 lesion in the stomach, where you want to show that is it a localized disease or has it become metastatic? So you need a CT scan. The classification of GNET is also done on the basis of serum gastrin levels. In type 1 and type 2, they are elevated. In type 1, they are elevated because of atrophic gastritis. The parietal cell output is low. Because of the negative feedback, the G cells become hyperactive, overactive, and they start producing gastrin. In type 2, it's the classical Zollinger-Ellison syndrome, which is a gastrinoma. But in type 3 and type 4, these features are not there, so they will have normal gastrin levels.
Dr. Puri, if I can interrupt you, you would like to take a break now?
Sure. Or let me finish. I think I'm on the verge of finishing GNET, if that's what you want, because we
Perfect.
can finish gastric.
Perfect.
I can just play. So this is an overview of the gastric nets. We divide them into type 1, type 2, type 3, and type 4. More recent publications are now clumped together type 3 and type 4, and they're put in type 3 only. And as you can see, I will also show you on my subsequent slide, what we see most likely in everyday practice, or most commonly that we're going to see, is the type 1. The rarest one is going to be the type 2. And as I mentioned earlier, the type 1 is associated with atrophic gastritis. The type 2 is the one associated with Zollinger-Ellison. And type 1 is most unlikely to have metastasis at the time of presentation, whereas in type 3, they're almost the rule, at least 50% of them would have. And there is an overlap, there is a lacunae in the WHO classification, because sometimes there's an overlap between type 1 and type 3. This means that there are multiple lesions in the stomach, which are all small, all from the same clone, but one of them becomes hyperactive and becomes a type 3 lesion. So that's why there's an overlap. So lastly, to give you an overview, what you see most likely or most frequently is the type 1, which accounts for 75%. Type 3 is 15%, and a Zollinger-Ellison is probably, one sees it once in a lifetime. And as far as clinical presentation is concerned, the type 1 is the one that is most likely to be incidental, because they have no symptoms or non-specific symptoms, whereas all the others, type 2, type 3, they will all be symptomatic with something, whether it's pain, vomiting, diarrhea, weight loss, etc. Govind, I'll stop here and we can take a break. Are you with me?
Can we, Govind, can we go ahead with questions, sir? There are a lot of questions which are coming.
Yes, please, Viji, please go ahead.
Okay. See, one of the first questions is, quite a few people have asked. Vaishali Dubey has asked this question from New Delhi. How to proceed with submucosal lesions, and if EUS is not available, what to do, is one of the questions, sir. Do you require EUS and all?
Okay, the briefest answer for this is just wait for the next 5 slides.
Okay, all right. The next question is, you said the enterochromophil cells are in the along with the other cells in the pit of the intestinal crypts. So, but this is mucosal. So, where do you get a tumor in the submucosa if it's a neuroendocrine tumor? Is one of the questions that has been posed.
Okay, so tumor cells are in the lamina propria. And if I can say from the lamina propria, to use an old cliche, some flew east and some flew west, and some flew over the cuckoo's nest. So some of them go beyond. In the westward direction would be into the musculus, split the musculus mucosa, go into the submucosa, whereas the others go towards the mucosal aspect and they form a broad-based polyp. So they are found, that's how penetration occurs, the deeper penetration, and this is best picked up by EUS.
And can we do biopsies, and how best to get a submucosal biopsy? What is your trick of the trade?
You can try submucosal biopsies by a well technique, but if you really want a deep biopsy, then I suggest you should go for an EMR. They would give you much more if you only want a biopsy.
There's another question, sir, from Prashant from Mumbai. There's a rule of thumb for neuroendocrine size of 2 centimeter being malignant. Does it work for gastric net also, T1, T2, as well as most of them are usually benign, he says? What do you think? The size, does it say malignant?
Size works for all neuroendocrine tumors except one, which is the ileum. The ileum carcinoids are the one that the usual size is around 4 to 5 millimeters, and they would be metastatic. So that's why I'd kept it. That was the ace up my sleeve. So since he's asked, but all these, all the others, the rule of the thumb, again, I won't go into how this thing was derived about rule of the thumb, but this is a general rule that if it is neuroendocrine tumor, everywhere except the small bowel.
And another question from Antrich from Chandigarh. Is donut-like umbilicated lesion in the stomach characterized NET, or can it be pancreatic cell rest? How to differentiate between the two endoscopically?
That shouldn't be too difficult, because a pancreatic rest is very deep into the antrum and it is solitary. You just have a solitary lesion. Whereas the neuroendocrine tumors in the stomach, the type 1, they are multiple and they are more in the acid producing area. So in the corpus, you would see them more in the corpus and towards the fundus rather than a single solitary lesion sitting in the antrum. But yes, you can get a depression on that, but one doesn't go only on the Sambarbada appearance. One goes by the number and the location.
Dr. S.K. Sharma from New Delhi has asked a question, sir. Combining chromogranin with another marker like enolase, I think he's talking about the neuron-specific enolase. Does it improve the yield? What is your view?
I'm not aware of any study where this has been used, and NSE has been used in the IHC. I'm not sure if there is any lab which is doing serum enolase levels, but IHC, yes.
Dr. Bhavin Patel has asked, why is the donut shape in the neuroendocrine tumor? Why does it look like a donut or a sambar vada?
No, it's like saying, why do you look like you and why does somebody else look like? I'm not sure I know the answer to that. If somebody does, I'd be happy to take it.
I don't know. Does it? Could it be because of the central necrosis that it can be like that, sir? A depression?
In most of these small 5-millimeter tumors, there is no necrosis. When you biopsy them, they come out. If you do an EMR or an ESD, they come out intact. There is no. So I'm afraid I don't think I can answer that question.
So Professor Dilavari has got a comment, sir. He says the patient privacy has to be maintained and face could have been covered or something like that. That's a comment he has passed.
But the face was covered, the eyes are covered as per the right.
In fact, yes. And neuroendocrine liver lesions, given the majority are hypervascular, these hepatic directed procedures which talk about ablative therapy, we are not talking about liver neuroendocrine tumors, primary. So should we skip this question? So I have one more question on Dr. Abhinav Kumar from Bangalore. 55-year-old male with ECOG status of 0 detected to have duodenal net of 2 centimeters in size arising from muscularis propria on EUS. What will be the approach which you will take in these patients? See, one is very surprising. It cannot be arising from muscularis propria. It could be a cyst. Surgical onco wants to do Whipples in an asymptomatic patient. Is that the right way, sir? It's a 2 centimeter duodenal neuroendocrine tumor, he says. Should we do a Whipples?
Would you do a Whipple? If it was my mother-in-law, I would send her for Whipples. But if it was somebody else, then I think duodenotomy is the right answer. Most of these patients you can very well manage. No, that's a very tongue-in-cheek comment, but currently it's the duodenotomy which is favored. You can the surgical duodenotomy is done. It can even take care of multiple lesions, and unless that is not possible, only Whipples is the last resort.
Ms. Sharad Dev from Varanasi has a question. Middle-aged man with multiple gastric net type 2, WHO G2 with no metastasis, but has chronic calcific pancreatitis. Is there a correlation?
To the best of my knowledge, he's describing a G2 is Zollinger-Ellison. Is that what he's saying? So to the best of my knowledge, there is no correlation between Zollinger-Ellison and chronic calcific pancreatitis. Maybe the patient was alcoholic, or I don't. The answer is that there is no definite correlation between the two diseases or association for that matter.
And there is a comment from Kim from Chandigarh to congratulate you for a wonderful talk on the deep into the pathology and understanding of the whole subject. Ankit from Kolkata, submucosal tumor mostly can be GIST. How to do biopsies, how to differentiate a GIST from a neuroendocrine tumor, an endoscopic biopsies or appearance.
So she's asking, the question is how a pathologist would differentiate between a gist or the clinician.
The clinician, sir.
Sorry, the
The
clinician.
Ankit from Kolkata, gastric submucosal tumor mostly could be cysts. How can we do the biopsy is the first one. How to differentiate from a neuroendocrine tumor clinically?
You can do the biopsy, serum chromogranin levels, serum gastrin levels, and if you still are in doubt, then the last word can be from the DOTA. But remember, the gist is another tumor which can also express somatostatin receptors. So these are the two conditions which actually both of them would show positivity on the radionuclide scan. So we would have to go by histology and the other clinical situation.
We can move on now, sir. We can move on to next part of your talk. We come back to questions again.
So I have noted the first question and I would be answering that shortly. So coming back to resuming the gastric nets, as I said, the type 1 is the one which is most likely to be an incidental detection. It has non-specific symptoms. And here I want to say that carcinoid syndrome is very uncommon with GNETs. But in medicine, so many times you have to eat your own words. So the overall management of GNETs depends on what is the grade of the tumor and the size of the tumor. And this I've summarized the NCCN guidelines, which is North America, and the European guidelines for neuroendocrine tumors. There is almost unanimous agreement that if the size is less than 20 millimeters, this size has been varying. In the earlier publications, it used to be 10 millimeters. So if you've read the earlier ones, it says 10 millimeters, some of them. But now I believe most of, whether it's the NCCN or the European ones, they've all decided that 20 is the cutoff. So if it's less than 20 millimeters, then you have two options. You can either put the patient on surveillance, and that actually works because some of these tumors lie dormant for years, maybe even a decade. Or if you wish, you can go in for endoscopic resection. And you have a choice here between EMR and ESD. I will discuss the comparison between these two. In the older literature, it was said that if you have less than 6 lesions, then you're justified in doing an EMR. But now currently this has been taken off. And so regardless of number, no matter what number of lesions, if the patient is willing and you have the patience and the expertise, then you can do an endoscopic resection, provided there is no invasion of the musculus propria or lymph nodes. And these guidelines also mention that if the patient is very elderly and has comorbidities, then maybe it's better to just wait and watch and put them on surveillance. If the size is more than 20 millimeters and there is suspicion of either musculus propria invasion or spread, then surgery is the only answer. And here we are suggesting an antrectomy should be done or a partial gastrectomy needs to be done. For NETs 2 and 3, it's very straightforward. It is the surgery of the gastrinoma, because the gastrinoma produces the gastrin. The gastrin causes the hyperplasia of the G cells, and ultimately you get tumors in the stomach. So once you've taken away the offending agent, which is the tumor, which is usually in the duodenum, then these tumors actually become a little atrophic and they probably die their own deaths. You don't have to do. But in case they're symptomatic, then you can also use somatostatin analogs for the control of diarrhea. For type 3 GNET, there is no confusion. It is surgery. And the only thing is, you can now even suggest a wedge resection if the tumor is less than 20 millimeters. So that is really for the surgeon to decide. So as far as endoscopies are concerned, we have two options with us. One is the EMR and the other is the ESD. The more recent one is the ESD. And as far as EMR used to be concerned, there is the concept of Lakshman Rekha in Hindu mythology. So the Lakshman Rekha means the line that you should not cross, and if you cross, you're in deep trouble, is the musculus propria. So the deep submucosa bordering on the musculus propria, if you find it on EUS, it is involved, then it's best that you don't do EMR in these patients, and they can still be considered for ESD, and that's the advantage of the ESD, and or taken up for surgery if the MP is involved. So this was one of the questions that was asked to me, and I hope I've answered it. So in short, the candidates for the EMR/ESD are type 1 and type 2 gastric nets. The size ideally should be less than 20 millimeters. The older literature said less than 6 lesions, and the depth of the tumor should be limited to this, at best, to the upper submucosa, and absolute no-no becomes the lymph node and liver mets. This is one such example, and you can see this is an EMR has been done, and this is the classical boiled egg appearance where the tumor is yellow and the surrounding mucosa is white. I don't think the colors have come out too well, but this is what we do when we do EMR. So the debate, it's really not much of a debate now. It's a straightforward thing. EMR versus ESD. Any day ESD should be preferred because it gives you the option of an R0 resection. Of course, it requires more skill, more training, high cost, but low recurrence rate. So sorry for the spelling. This is a low recurrence rate. So clearly the scales are shifted in favor of ESD. However, if you are not skilled and you think the patient it doesn't have any risk factors, and because of the low cost issues, then EMR can also be attempted. So once you've done an endotherapy for them, whether it's EMR or ESD, how do you follow them? So the general recommendations are nearly the same, whether you take the ENETs or the American NCCN. It is for type 1 endoscopy every 6 months for 3 years. And after 3 years, then it becomes an annual endoscopy. The next is now duodenal nets. And again, duodenal nets are uncommon tumors of the duodenum. They comprise less than 5% of all duodenal tumors. So this is where we are. Most of the tumors in the duodenum are going to be not related to the neuroendocrine tumors. If you look at it from a different perspective, then of all the GI nets, the duodenal nets compose only about 5%. The commonest sites are the stomach and the rectum. So these are the commonest site for the GI nets, and then the small bowel. And the duodenum is distinctly uncommon. This is again a picture, an endoscopic picture, classical. Again, we've come down to the donut level, and this you can see is ulcerated. And if this shows ulceration, then in that situation, these ulcers can also bleed. But what I wanted to show over here was, one, that they are sessile lesions, as I've been stressing, that they don't form a nice thin stalk that you can just cut with a polypectomy snare. They are very broad tumors, so therefore higher chances of bleeding. And as you can see in this slide, they may be multiple. And for some obscure reason, I don't think I have the answer to that. They are only found in the first and the second part of the duodenum. And in the third part is just about 5%. So you can see that the vast number of duodenal nets, almost 90%, for some unknown reason will be found in D1 and D2. There must be something in the local environment in D1 and D2 which the nets like very much, and that's why they are most likely to be found in this way. So if I have a submucosal tumor in the D3, then the likelihood of it being a neuroendocrine tumor is distinctly less or uncommon. And usually the tumor size in most of these patients is 20 millimeters in nearly 90% of the patients. 90% of these are non-functional. Again, this is as compared to the small bowel. And the ZE syndrome or the gastronoma is seen just about 10% of all duodenal nets. Can you suspect new duodenal nets? In two clinical situations, yes. One is these patients who have neurofibromatosis. They are the ones who are most likely to have duodenal neuroendocrine tumor. They could be near the papilla or at the papilla. And the other patients is those who have Zollinger-Ellison syndrome. So if you suspect clinically, you make a diagnosis of either of these two, then the chances of finding a neuroendocrine tumor is in the duodenum is going to be very high. This is the data that we had from GB Pant. It wasn't published, so I haven't put a reference. But what I'm trying to show over here, of the 23 odd cases that we had, the periampullary are the minority. Majority of them were not in the ampullary region, because it is the ampullary region which are most likely to present with either obstructive jaundice or cholangitis. And some of these tumors at the ampulla are the paragangliomas, which are classified with the neuroendocrine tumors, but they are very, very benign. But their characteristic feature is that they light up like a bulb. They are big tumors, and if you do a contrast CT in the arterial phase, they really light up. So what about the management? So again, we have very clear guidelines from both the societies which say that if you have less than 1 centimeter or 10 millimeters, if periampullary, then you can go for surgical resection. I'm not very convinced with this, because even if it is a periampullary, you can actually do, in the case of a paraganglionoma, you can do using just a polypectomy snare. You can snare it, or an ampulectomy can be done if you're reasonably certain. If they are in the duodenal, away from the ampulla, then you have a choice between endoscopic resection, which is ESD or EMR. We have very clear-cut guidelines, which is more than 2 centimeters. Then after EUS and CT, it is mostly, they would be taken up for surgery if the lymph nodes or mets are present. And if distant mets are there, then you might require PRRT or specific chemotherapy. The gray zone is actually between 10 to 20 millimeters. And there you have a choice. So if you have a very skilled person doing ESD, you can do that. Or alternatively, you can send these patients for duodenotomy, which was considered. And here again, I would repeat the same statement that Whipples should be kept as a reserve. It's the duodenotomy, which is the preferred surgery for duodenal neuroendocrine tumors. And lastly, because we're running out of time as well, rectal nets. So 2 clinical questions. How commonly do we encounter them in routine practice? And how would you manage a rectal net if there was no distant net? So I'll try and answer these questions. The answer to the first question, if you are in Japan, then this might be the commonest neuroendocrine tumor that you would pick up. I don't know the explanation for that. Maybe something in the Japanese diet. So rectal nets are common in Asian populations. Specifically, the Japanese data suggests that rectum is the commonest site. As I mentioned earlier, most tumors are less than 10 millimeter size, and they are detected incidentally during colonoscopy. They have a very favorite position, which is roughly about 7 centimeters between 7 to 10 centimeters from the anal verge. That's the commonest, that's a mid-rectum. The typical appearance is a small sessile polyp that you would see, a rounded structure, and uncommonly, so less than 10%, they would have a MET, provided they are less than 10 millimeters. So, giving again an overview, and you take the entire GI nets, then rectal nets would compose only about 20% or so. And if you're in Japan, probably this would be much higher. This is the 10-year experience, a large series on rectal nets. And you can see the majority of them are G1, and only 2 out of the 37 were neuroendocrine carcinomas. Muscularis propria invasion, 1 out of 37. And you can actually do, this was an older study, so they were doing EMR. ESD probably wasn't done at that time. So they were able to do in practically more than 95% of the patients, and with an excellent local recurrence rate of just 2 in 35. This is the typical appearance. I showed you this picture earlier. It's a very typical submucosal tumor that you can see raised, 10 millimeter size. And here, this patient had to be operated because you can see that it is going right into the muscularis propria, unfit for any endotherapy taken up for surgery. So the options for the rectal neuroendocrine tumor, again, the same, EMR and ESD. And here you would have to decide between the surgery is sphincter sparing or a low anterior resection. The guidelines, again, you can see there's so much commonality between all these sites. So rectal NET best suited for EMR and ESD. If it is between 1 to 2 centimeters, again, no definite guidelines. But I guess, as I said earlier, if you have a person experienced in ESD, then that might be the best alternative. But if you have a rectal NET which is more than 2 centimeters, then possibly it should be considered at par with adenocarcinoma and managed accordingly. So coming to my conclusion, the last slide, the nets of the stomach, duodenum and rectum are mostly non-functional and not associated with carcinoid syndrome. In the last 3 decades, all over the world, we are seeing an increased incidence or a rising incidence of the foregut neuroendocrine tumors. The risk of local or distant spread depends on the histological grade and mostly would occur in patients with grade G3. EMR and ESD are appropriate therapies for most foregut and hindgut tumors if it is less than 2 centimeters. And EUS and DOTA scans are very important investigations which have made a mark in the last 10 years to document local as well as distant spread of all neuroendocrine tumors. Thank you very much. I'll just take the questions now.
Dr. Puri, you had some questions for audience?
Yes.
Yeah. What is a tumor of less than 10 millimeters being malignant? One major exception.
You're asking me?
Yeah, you only said you would speak.
I gave you the answer. Vijay, you weren't listening. Ileum.
Yeah, he got that.
Okay. There are questions from the audience.
Dr. Vijay Mohan Prasad, Dr. Puri has a couple of questions for audience poll. So let's take those questions first.
From the audience?
Yeah, Dr. Puri has some questions.
Oh yeah, sure, please.
Dr. Puri?
Yes.
You had some questions for audience?
I sent you on the mail.
Oh, okay. All right. Okay, we can start some questions.
Okay, I think I'll take up a few questions now for the audience. Paul thing can wait. Amrinder, an excellent talk, very lucid, very clear. I think you got a lot of appreciation from Dr. Kim Wai-Fei. Rajneesh Gulati also appreciated this, your presentation from Delhi. I'll come to some, a lot of basic questions have been asked that need to be clarified. And I think we can probably stop sharing the screen now.
Oh, we can stop sharing the screen, yeah.
Amrinder, you can stop sharing the screen.
Okay.
Right. Dr. Sukanto from Dhaka, Dr. Kanika from Bombay, and Dr. Baral from Nepal all want to know about the Ki-67 index. What does the Ki stand for? How does it compare with the mitotic index? And how exactly do you use the Ki-67 index, Amrinder?
Well, this question should be addressed to the pathologist, but actually what it tells
on the mantle, you talked so much pathology.
Okay. So Ki, as I understand, I asked this question myself to somebody, and I was told Ki stands for Kiev. Kiev is a city in Russia.
Russia. Okay.
And since it was discovered by given for the first time by the pathologist there, so that has stuck on. So that's Ki stands for Kiev. And what it tells you is the mitotic grade. So if you have a Ki-67 less than 2%, so it probably means it's a very indolent tumor, and you can put the patient on surveillance if you wish. On the other hand, if it is Ki is more than 20%, then obviously it's a high-grade tumor and should be tackled ASAP. And that's what it tells you. And this is done by on the histochemistry by the pathologist. It's not a clinical thing. It's done on the specimen that you give them. They would run it and do the IHC and tell you.
I think you mentioned both the mitotic index and the Ki-67 index. So what are the different pieces of information you get from these indices?
Both are essentially the same. I have always thought that there's never been a discordance ever that I've seen between the. Maybe this question should go to the pathologist if there is one. If Kim is listening.
Well, you are doing the fielding and the batting this time. Okay. Similarly, I think Dr. Arun Singh from Indore, again, a lot of Ki-67 question, says if the Ki-67 index is less than 3, but metastases are present, how would you classify this patient as a benign?
Then it is definitely metastatic disease. This is a rough guide. Once you've documented metastasis, then this can occur. It is very unusual, but in medicine, you can never say never. So this is definitely unusual. But once it is metastasized, then it is taken as metastatic disease.
Right. Dr. Zahir from Hyderabad wants to know about the duodenal nets found incidentally are fairly common. Should all of them be subjected to the full workup, imaging, Dotanok, chromogranin, or would you like to be selective and pick and choose where you would do a complete workup, say by the size of the tumor?
Yes, definitely the ones which are bordering on 20 millimeters, I would be more aggressive. Vis-a-vis those which are less than 10 millimeters, we can actually put them on surveillance. But of course, if it is a duodenal net, I would always do a EUS in these patients. That is one thing. And if there's reason to suspect that there is at EUS I'm getting lymph nodes, then of course then you go for DOTA.
Okay. Okay, so you need to be selective and choosy rather than doing everything in all the patients all the time. Okay. Dr. Vimal Saradeva from Rajkot is asking that is the increased incidence of GNETs due to overuse of PPI, or is it gastric atrophy due to increased H. pylori? Are these factors that are responsible for the increase, or it's only better imaging?
I would tend to agree with him that one of the reasons could be that the way PPIs have come in the last 3 decades or so, there has definitely been a constantly increasing incidence, rising incidence of this. So but in this part of the world, in South Asia, possibly it is the H. pylori related chronic atrophic gastritis which causes more of hypergastrinemia than PPI, because our patients, if you have CAG and even if you give them PPI, nothing is going to work. So it's the atrophic gastritis which is possibly
be responsible. Right. Thank you. Dr. Gayatri from Bangalore and Dr. Sharad Deva from Varanasi have a similar question regarding gastric nets and malignancy in these polyps, for whether in for adenocarcinoma in the atrophic stomach. What is the intention behind surveillance?
Sorry, so there was a break in the audio. I missed the question.
No, so when you're doing surveillance in type 1 gastric nets for malignancy, are you surveilling the polyp, which is the tumor itself, or are you surveilling it for the atrophic gastritis in the stomach with atrophic gastritis for adenocarcinoma?
No, the surveillance is done only for the size of the polyps to see whether they're increasing. Once you've documented chronic atrophic gastritis, that will be done at the first. And if you document H. pylori, then you treat accordingly, because there is a chance that once you clear the H. pylori, then maybe the reversal to some extent may occur. So you are not documenting, you're not doing surveillance for the chronic atrophic gastritis.
Okay. Right. And any information about these mixed adenocarcinoma and neuroendocrine tumors? What is the thought on that? That there may be tumors that are adenocarcinomas with neuroendocrine component vis-a-vis pure neuroendocrine cancers in their presentation and management. Is there a difference? This is Dr. Sharad Deva from Varanasi wants to know.
I think this is an excellent question. First, the mixed adeno and neuroendocrine tumors are distinctly uncommon, and you would actually need an oncologist to answer this question. But in the clinical behavior, it is well known that in those patients who have the mixed component, only one can be metastatic. That means that if this patient has a metastatic lesion in the liver, and you biopsy it or FNAC it, and you send it for immunohistochemistry on the biopsy specimen, then it will show positivity for synaptophysin and chromogranin and everything. So it is only the NET which is metastasized, but when the pathologist, when you take a biopsy from the stomach, then there'll be a mixed component that you will see the pathologist will report both. And only they are.
Can I add here? We in fact had an interesting case of manic tumor. The patient presented, a middle-aged lady presented with abdominal pain, acute abdominal pain, had intestinal subacute small bowel obstruction. So which was shown on CT enterography, and then it was near total. So resection was done, and it turned out to be a manic tumor. So that was one case that I've seen.
Yeah, they are distinctly uncommon. So I don't think we can just, there'll be occasional case snippets, so to say, or isolated experience.
I think there are a lot of questions related to how you obtain biopsy in I think you addressed actually during your talk. The way to get a forability is limited. So, well technique or taking biopsies by EUS FNA, what would be simple standard mucosal biopsies? What does a usual conventional endoscopist do?
I think the conventional endoscopists would have to go by a jumbo biopsy forceps. These are small lesions. They are usually 7, 8, 10 millimeters, and a jumbo would take the entire thing. So there is, if anything, you can try doing a well technique, but if there's bleeding, then there's a problem with that. So multiple sites can be, for example, in the duodenum and in the stomach, where there are, when you have a multiplicity of tumors, your best bet is to sample as many sites. In the rectum, NETs are always solitary, so you don't have that liberty. So you have to take that whole thing, a whole chunk, and hopefully you get it. But there is no specific technique for doing a biopsy. These that I can tell them that you do it this way.
And I have a question from Professor S.L. Brewer. He has asked, what is the risk of perforation and bleeding with EST for neuroendocrine tumors in D1? You're doing in D1 or even D2. People are scared to do EST. So because of risk of perforation. So how to overcome that?
There is a definite risk of perforation that occurs, and the risk is probably more in EMR, which is a blind technique, as compared to ESD, which is your, and the advantage in ESD, you have the you have the clips in your armamentarium right there. So whenever you're detecting it, but the overall figure is anywhere between 5 to 10%, and it's more in D2 as compared to D1.
So I think, Vijay, you have more questions. You could please go ahead and take some questions for the next 5 to 7 minutes.
You want me to go ahead with the questions from the audience?
Please. Yeah.
Yeah. Okay. So, what is the most common neuroendocrine tumor overall? Is a question from Pondicherry. I think Sir has already explained that. And then, what is the role of PET-CT? Many of them are asked in a neuroendocrine tumor and isolated gastric or duodenal net. Do you do a Dotanac, somatostatin, PET-CT, octreotide, lanreotide, PET-CT and all that? Is it necessary in all cases?
Certainly not necessary in all cases, but I would do it in those patients, for specifically in the stomach, for type 3, which has a propensity to metastasize, and it has a tendency to go into the bones. So in those specific situations, I would definitely order. Or when I have a histology which says G3, I would do it. If I have a histology tells me G1, then I certainly would not do it unless there's something very pressing or the patient demands it. But so you have to kind of pick and choose. And you go by the size, you go by the G1 grade or the biopsy, whatever the G grade is. And if their patient is symptomatic, bone pain or something, then you would have to decide on that. But the vast majority, at least in stomach and duodenum, you do not need there is no indication for doing the PET DOTA scan.
And Parag Deshmukh from Nagpur has asked, if you choose surveillance against the endotherapy for GNET of less than 10 millimeter, then what should be the frequency and duration of surveillance? How often would you call it back? 6 months, 1 year, next endoscopy?
So different guidelines are very similar on this. It's always between 6 months to 1 year if you are just putting the patients on surveillance. But if you have done an endotherapy and you are looking for local recurrence, then you call the patients back every 3 months, at least for the first 1 year, or maybe even 2 years. After 2 years, you can make it annually.
Anil Kumar from Mysore, sir. He has asked, is there a medical management for neuroendocrine tumors that you were speaking about, the gastric and duodenal rectal? Is there a medical management or is always endoscopic or surgical resection?
No, it is endoscopic. There is no, the role of chemotherapy is only in NEC. There is no role for chemotherapy in patients with type 1 or type 2, or if the patient is symptomatic in the Zollinger-Ellison syndrome, then you can give the SSA, somatostatin analogs. But otherwise, the standard chemotherapy or specific therapy or PRRT is only for the NEC, neuroendocrine carcinoma.
I think all of you agree, then probably we can stop here. We are running over time.
Yeah.
So a couple of words I want to say about Dr. Puri's talk today. We'll say a very creative talk, very creative. The way you explained the pathophysiology of neuroendocrine tumors is so wonderful. And I think this talk is delivered really like a master who understands the cell biology of neuroendocrine cells, how they spread, how the manifestation appear. The whole talk was very, very creative. The way you explained to us regarding handcuffs and taking the smartness of DOTA having 2 pockets to bind somatostatin and gallium is remarkable. I think this is getting ingrained in my mind and remember it for a long time. The way you explained the sambar bada analogy, the way you explained the boiled egg. Are we going towards the...
Locked in your mind.
Absolutely, it's locked in the mind. And also, at the same time, so are we going towards the old-time pathologist explaining very pathology stuff using the analogy from food we eat?
No, I'm a foodie.
Absolutely, it looks like it's very obvious. It's very obvious. So it's a wonderful talk all over. And you and Dr. Kim very aptly said that the understanding you have about pathology and the way you explain pathology is remarkable. Is remarkable. So I think all of us enjoyed your talk very, very much, and to all our viewers that these talks have been put on Masterclass ISD website, and you can log on to listen to these talks again, or you can log on to these talks on Facebook also, and also on YouTube. If you go to YouTube, you go to ISG, Indian Society of Gastroenterology, and you find all the talks being archived at YouTube too. So I think many of us would like to go to these talks again and to listen to the beauties of these talks. Thank you so very much, Dr. Puri, again for a wonderful talk and creative talk.
Special thanks to Dr. Saraswat, Dr. VG, and yourself, Dr. Govind. Thank you very much.
Thank you so very much, Dr. Vijay Mohan Prasad, to very graciously coming to join and to moderate this session. And the way you asked questions were really, really remarkable. We thank all the viewers who are, as Dr. Saraswat said, they are very loyal viewers to these master classes. And thank you so very much for...
How many, what was the audience number? No.
Today about 800 or so. So thank you everyone. Thank you Dr. Saraswat for again support all along the masterclass courses. Next talk will be on next week. This will be a 16th talk, and this will be a talk again. It's a topic which is again very important for us. That is, how do you diagnose and treat alcoholic hepatitis? And the talk will be delivered by Dr. Kausal Madan. Dr. Kausal Madan is also Secretary General of INASL, and he is a very good speaker. So that talk will happen on 21st of June 2020 at the usual time of 12 to 1. So we'll log on again next week for another talk, that is a talk on alcoholic hepatitis. Thank you very much. Thank you, everyone. Thank you, technical team. Thank you, Ramesh ji. Thank you, Amol. Thank you, Yogita. And thank you, everyone. We'll see you next week or next Sunday.
Thanks to Ramesh from my side for fixing the problem. I was on hooks, tenter hooks, that we're not going to go on air. So thank you, Ramesh. And
all worked out. Yes, excellent.
Thank you, everyone again. I will see you next week, next Sunday, 12 to 1, for a talk on alcoholic hepatitis. We can log off, and bye-bye.
Bye.